want to get recording going. Good afternoon, everybody. So we are back with a cardiology series this week and next week. As you have seen the program, it starts today. We have lectures on Wednesday and Friday, and then we'll have 2 more lectures next week, and we'll conclude next week on Friday with a session where we will recap all the presentations that have been done during the 2 weeks period and take more of your questions at that time. As usual, we will have a presentation initially. You'll send your questions as you are listening to the presentation via the chat format. I will then moderate at the end by bringing up all your questions to Dr. Henok. Dr. Henok has been a presenter in the past, so most of you probably know him. He is an interventional radiologist, originally a graduate from Jimma University. He's currently in a private practice and in Dallas, Texas. He is also an adjunct faculty at Louisiana State University as an interventional cardiologist, where actually he was a faculty member there full-time until recently. Today's presentation is on acute coronary syndrome. And as I stated earlier, please, if you have questions during the presentation, use the chat format and text it to me. And enjoy the presentation. And Dr. Henok, the floor is yours. Thank you.
Well, good morning. A little bit of correction. I am interventional cardiologist, not radiologist. But Professor Girma, he wants to give me some more. Anyways, my colleagues, Dr. Mikias, I see him, and Dr. Tesfaye Talila. We have 5 topics in the next 2 weeks. Today gonna be acute coronary syndrome. Wednesday, basic EKGs by Dr. Mikias. And on Friday, introduction to structural heart disease by Dr. Tesfaye Talila. And then we're gonna have a clinical case with echocardiography with Dr. Mikias, and the last gonna be AFib and AFLATA. So just we would encourage you to give us some feedback if there are some topics you want to cover, because these are the topics just we picked from this side we thought would be good start for the cardiovascular topics. And also we would encourage also some staff from the Ethiopian side to participate if you want to give some lectures at the same time. So I'm going to present acute coronary syndrome. I have a lot of slides. Professor Girma is watching on timing, but the slides are to share with you, and then probably you can review it when Malaku send you the full slides. So acute coronary syndrome, what I'm going to do is basically to go overview of what we call them the acute coronary syndromes, and the basic pathophysiology and approach to diagnosis and treatment. In general, coronary artery disease presents in different, presentations with starting or from stable angina all the way to sudden cardiac death. You have also unstable angina, non-ST elevation MI, ST elevation MI, CHF, and arrhythmia. So the ones I'm going to concentrate the acute coronary syndrome are these 3 ones: the unstable angina, non-ST elevation MI, and ST elevation MI. So if you see on this kind of busy slide, this is a decline in cardiovascular deaths almost in the last 70 years. This is deaths per 100,000. In the early days, about 500 people per 100,000 deaths. Of course, this is from the United States. And if you see the graph, you see the continuous decline in the mortality of cardiovascular disease to almost below 100 per 100,000. And this is, you know, from the initial identifying the risk factors for coronary artery disease, introduction of beta blockers, and then the development, the introduction of also statins in the 70s, and then bypass surgery and balloon angioplasty, stenting, and so on. And as you can see, there is significant decline in the cardiovascular deaths in the last 70 years. So this is the basic anatomy. When we talk about coronary artery disease, we are talking about the coronary arteries. There are three major coronary arteries. You know, they originate from the base of the aorta, and there are some outpouching, we call them sinuses. This is the left coronary sinus, right coronary sinus originates the right coronary artery, and here is the left main, divides up to the left anterior descending artery and circumflex artery. So basically these are the major coronary arteries. Of course, they have different branches. So we are talking about these of this coronary artery. This is simple angiogram we do in the cath lab. So acute coronary syndrome refers to a spectrum of clinical presentation associated with rupture of an atherosclerotic plaque. So, and partial or complete thrombus of coronary artery disease. So the theory at this time, that's the main cause of acute coronary syndrome is when you have plaque rupture. And the plaque rupture can cause unstable angina. If it's bad enough to cause ischemia, can cause myocardial necrosis, which manifests with biomarkers. And if there is complete obstruction of flow, and you have the ST elevation myocardial infarction. Basically, the ST elevation is when you don't have any flow, complete obstruction of the flow to the myocardium. So this is again the data from the United States, about 1.5 million admissions of acute coronary syndrome per year. The bulk of those admissions are the what we call them the non-ST elevation MI. That means unstable angina and non-ST elevation MI. And about 0.3 million are the ST elevation MI. So just I'm gonna go, you know, on the different definitions. Basically, ST elevation MI, as its name, you see ST elevation on the EKG. And what that means is there is acute myocardial injury with no blood flow on that specific coronary artery. The non-ST elevation MI and unstable angina, basically they have chest pain, they don't have ST elevation, they can have T-wave inversion, ST depression. But the difference between the two is you have biomarker elevation in non-ST elevation MI with troponin, and you don't have any biomarker elevation on unstable angina. So basically those are the definitions of the three items in the acute coronary syndrome. So if you see here, you have ST elevation MI, and here non-ST elevation MI. If troponin is negative, it's unstable angina. If troponin is positive, it's non-ST elevation MI. So just I'm gonna go over cases that I have done over the years, so that just show you what the difference of the three items we are talking about today. This first case is 69 years old, white male patient with hypertension and chest pain, and typical anginal pain. As you can see, the EKG is not impressive, and these patients, we do risk stratification, and some of the patients, if they have negative enzymes, no significant EKG changes, the only presentation is chest pain, we end up doing stress tests. And this is the stress test. Basically, the heart is cut into cross-sectional section, and basically just the upper part is the stress part, the lower part is the rest part. So we compare stress on rest, and you know, there is a defect here. We call it reversible perfusion defect that comes at rest, but decreased blood flow in this area of the heart at rest, at stress. So that's why we call it reversible perfusion defect. And then this is angiogram, right coronary artery angiogram. As you can see, there is good blood flow here. There is no any decrease in the TIMI flow, but if you can see, there is some narrowing of the coronary artery here. Usually such narrowings, we call them actually intermediate if they are between 50 and 70%. But regardless, because it's positive stress test on the scan, then this patient ends up having putting stent on this coronary artery. So this patient presented with unstable angina. So I don't know whether you can see the stent, but if you can. So there is stent here, just I'm gonna run it, and sometimes it's very difficult to see, but there is stent here in the right coronary artery. So the second is a 54 years old patient with history of hypertension, chronic history of smoking, present with chest pain, pressure, and his troponin was 1.19. If it is the EKG, the same thing. It's not very impressive, except there are some pro-airway progression on the anterior lids. So increased biomarker, no ST elevation. This is what we call it, non-ST elevation MI. And if you can see this angiogram, still you have flow, but you see you have ugly rupture plaque here. I'm going to show you on the histology what it looks like, plaque and plaque rupture. But sometimes these patients can present also with ST elevation MI if this flow sometimes, you know, stops and dynamic. You know, you can have some flow. Sometimes you may not have some flow. Patients may present with ST elevation MI. But this patient, he didn't have ST elevation on the EKG, but he had biomarker elevation. And this is what we do in the cath lab. You can see the stent put in on the mid LED. And the last one, the last case is ST elevation MI. So this is self-explanatory. Patient with chest pain, you see the EKG, anterior leaders, he has ST elevation. And this is very critical to identify these patients because it's medical emergency. ST elevation MI is a kind of a different monster in terms of approaching how to treat patients, because these patients need to be revascularized within 90 minutes, whether it's balloon or catheter based, or reperfusion with thrombolytics. So if you see this angiogram, you don't have any flow here. So basically this LED is cut off. There is thrombus here, and the artery was supposed to come this way down. I'm going to show you once we open the artery what it looks like. But when we talk about ST elevation, what that means is there is not any flow. So these patients, you know, just needs to be approached to have revascularization immediately. In our settings, in the Ethiopian settings, I know there are not much, you know, cath labs in the country, especially in the regions. Probably, I think thrombolytics may be available in the big cities, I suspect. So the only thing we can use is just to use thrombolytics. But the most important thing is to identify those patients who have ST elevation that can benefit from thrombolytics. So you see this is balloon angioplasty. You balloon the artery, open it up, obtain flow. And this is the flow you see. There are some wires here. I am not going to go into the detail, but that's what stenting and you know, obtaining TB3 flow looks like after intervening patients with ST elevation MI. So the basic mechanism of acute coronary syndrome is plaque rupture. So what we talk about plaque is, so this is the histology of, you know, the cross section of a vessel. If you see this vessel, there is lipid core here. So this lipid core is covered with this one, we call it fibrous plaque. So the fibrous plaque, the thickness of the fibrous plaque to the lipid core determines whether the plaque is vulnerable to rupture or not. So if the fibrous plaque is thick, we call it stable plaque. But if you see here, there is very thin fibrous cap and big lipid core here. And if you see here, these are what we call the vulnerable plaque at the shoulder. Once this ruptures, it attracts platelets and then the clot formation in the acute coronary syndrome. So this is what we call the stable plaque and vulnerable plaque. These are the plaques that easily can rupture and can cause acute coronary syndrome. So if you see here, you have large soft fatty core. When it ruptures, you have blood clot here. If you don't have flow, you have ST elevation. If you have some flow with myocardial ischemia, you have non-ST elevation MI, and so on. So if you see this angiogram, you see that's the ulcerated plaque we are talking about. This is angiogram. This is IVUS intracoronary ultrasound. We put inside the artery to look what it looks like, the wall. When if you see here, there is plaque rupture, disruption of the endothelium. So basically, you have angry platelets. When you have acute coronary syndrome, look at these platelets. When they are activated, you know, they look angry with some pseudopods, and they are ready to aggregate and form blood clot. And when we have thrombus, what we have is we have platelets, we have thrombin, and we have fibrin threads. So basically, the treatment aims at antiplatelets, antithrombus, and fibrinolytics. That's why we use all those drugs for the treatment of acute coronary syndrome. Risk factors, as you know, smoking, dyslipidemia, hypertension, diabetes, obesity, and non-coronary atherosclerotic disease. What that means is patients who have peripheral vascular disease, patients who have carotid artery disease. Those patients, 20% of them, they have also coronary artery disease. So if they have disease in any other vascular bed, they have more likely increased risk of having also disease in the coronary arteries. And of course, we do troponins. We are away now these days from doing the CK-CK-MB. Troponin is very sensitive and specific, and it elevates and stays in the system for 7 to 10 days, and also has prognostic sign. You know, if you have increased troponin, you have increased mortality or morbidity, because what troponin tells you is, you know, the size of the myocardium that's damaged, basically. And there are some conditions that have increased troponin, but they don't have, you know, real acute coronary syndrome or coronary artery disease. These as PE, congestive heart failure, sepsis, LVH. These are the kind of items, you know, the kind of conditions that you can have troponin elevation, but you don't have acute coronary syndrome. Of course, you're going to do the history, and you're going to have other testing modalities like echo and so on. But it's very important to identify also these patients who have troponin elevation, but they don't have acute coronary syndrome, because the approach is different. So basic approach to ST elevation and stable angina and ST elevation MI in sudden cardiac death. Basically, the medical arm of the treatment is almost similar. So we have the medical treatment. This is what we need to concentrate, especially in the Ethiopian setting. We have to give the patients nitrate for pain relief, aspirin, and heparin, whether it's low molecular weight or unfractionated heparin, beta blockers, S inhibitors, statin, and the P2Y2 inhibitors in patients with acute coronary syndrome, whether they go to left heart cath with stenting or not. and also percutaneous coronary intervention, bypass. And on the non-ST elevation, ST elevation MI, we used to use the glycoprotein 2B3 inhibitors. We are not using them as we used to because of, we have now potent antiplatelets. And of course, for STEMI, primary PCI or thrombolytic therapy is the initial treatment approach. So in acute coronary syndrome, basically understand when we see ST elevation MI, we have no flow on that artery. So early restoration of coronary blood flow, full restoration of flow, and sustained flow. And if you see this graph, this is the relationship between myocardial salvage and survival. This is the timing. Basically, time means muscle in terms of acute, in terms of ST elevation MI. So if you see the earlier intervention, within 90 to 120 minutes, that's where it comes the recommendation for ST elevation MI to reperfuse within 90 minutes is, we reduce mortality in the early stages by opening the artery. But once it passes 3, 4 hours and 12 hours, the benefit declines significantly. So the goal is to perfuse the patient with ST elevation MI within the first 90 to 20 minutes by balloon angioplasty, balloon-based treatment, or thrombolysis. I suspect Dr. Mikias gonna dive a little bit on the thrombolysis part when he presents on his case. So the myocardial reperfusion, primary PCI, fibrinolytic therapy, and acute surgical reperfusion. Very rarely we send patients for emergency bypass for ST elevation MI because these patients, that artery needs to be opened as soon as possible. But there are some times that we may not be able to open the artery, or the patient may have some flow and they may have significant disease on the other arteries that we think are benefit from bypass surgery. So we send them those patients to bypass surgery. These are the different thrombolytics we use here in the United States. I have never had any experience with giving thrombolytics because most of the patients, we take them to the cath lab, but I receive a lot of patients who receive thrombolytics out in the community, but we send them anyways for heart cath and stenting. But TNK is the one we usually use out in the community because it's one dose, a bolus dose he gives them, and then they send them the patients anyways. But to see the effect is, to wait 60 to 90 minutes. But according to the current guidelines, even after thrombolytics, most of these patients, they end up having heart caths in our labs. So this is a slide. If you see PCI, primary PCI versus thrombolysis, as you can see, catheter-based intervention beats thrombolysis on days, non-fatal MI, recurrent ischemia. Hemorrhagic stroke, there is increased risk with thrombolytics, but other major bleeding, there is some increased risk with PCI. But overall, if you have access to cardiac catheterization lab, the best thing to do is take the patient to the cath lab and open that artery. So these are the indications for ST elevation MI in our setting. The 90 minutes is what we use to reperfuse patients within 90 minutes. But if they are coming out from the community, it's 120 minutes as a guideline. If they can reach to the hospital within 120 minutes, still they can send them the patients without giving them thrombolytics. But if there's going to be some delay, or if the patients they cannot reach within 120 minutes to a hospital, they give them thrombolytics. So these are some of the contraindications to thrombolytics: prior intracranial hemorrhage, intracranial neoplasm, structural cerebral vascular lesion. ischemic stroke within 3 months. Of course, you know that acute stroke, some of the patients they get thrombolytics within the first 3 to 6 hours. So this is out of that window within 3 months. Patients who have suspected aortic dissection and active bleeding and closed head trauma within 3 months. So the medical, you know, the treatment unstable angina and ST elevation MI. We use the TIMI score. This is very important tool to use. Patients who come with unstable angina and non-ST elevation MI. This is to risk stratify, you know, the patients that would benefit from taking them to the cath lab. So it's simple 7 points: the age greater than 65, coronary artery disease risk factors greater than 3, prior stenosis of coronary artery disease greater than 50%, ST deviation, also greater than 2 anginal events in less than 24 hours, aspirin in last 7 days, and elevated biomarkers. So if you can put these numbers, once you know the TIMI score is 2 and above, you see the risk of DSMI urgent revascularization increase dramatically. So these patients, to identify these patients is just to take them to the cath lab for coronary angiogram and possible intervention. So the anti-ischemic treatment, bed rest, nitroglycerin sublingual, and supplemental oxygen. If their pulse oxy is less than 94, we give them morphine, you know, for pain. Is that from my side, Malaku? I see a lot of...
No, it's not you. I think there are people who are playing with their screens and using the annotate function. Please do not draw on the annotate function, but keep going, please.
Yeah, so beta blockers, we can initiate beta blockers within the first 24 hours unless they have, you know, decompensated heart failure, low output, and cardiogenic shock. Also, patients, especially if they are ejection fraction less than 40%, we put them on SE inhibitor. Or if they have, you know, massive anterior MI, we put them on SE inhibitor. If we don't use SE inhibitor, you can use ARB. And this slide is on the importance of putting these patients on statin. Statin, as you know, is the main state of treatment for acute coronary syndrome, even for coronary syndrome. And we have different studies that prove that effect. And the dose of the statin, we use it, what we call it, high dose statin. The high dose statin is 80 milligram of atorvastatin. So these different studies, the PROVE8, A2Z, TNT, IDEAL, all these studies have shown high dose statin is beneficial to patients with acute coronary syndrome. So any patient with acute coronary syndrome, they need to be on statin. So by doing this medical treatment, the aspirin, the Plavix, the beta blocker, the S inhibitors, and statin, you can see how much risk reduction we can do to these patients, even though if we don't have even cath lab, by applying, you know, giving all this treatment, these are, you know, they have data on these ones, on the beneficial effects of the aspirin, Plavix, the beta blockers, S inhibitor, and statin. So by giving these medicines, we can reduce by close to 77% on the cardiovascular event rate. And these are the antiplatelet agents we use, the COX inhibitor, aspirin, and the P2Y2 receptor blocker, and the glycoproteins 2B3A inhibitors also, even though we are not using them as much as we used to use, but the P2Y2, the Plavix, prasugrel, ticagrelor, ticlopidine. Of course, we are not using the ticlopidine anymore. It was in the earlier days. So aspirin is very important to give them 160 to 325 milligram. This results in immediate and almost complete inhibition of thromboxane A2 production. it will have a rapid antithrombotic effect, and more rapid observation occurs with non-enteric-coated formulations. And the P2Y2 inhibitors, the purpose is to prevent platelet aggregation, prevent platelet fibrin-rich plaque from forming at the site of vascular injury, thus protect the myocardium from ischemic injury. And the P2Y2, we have the thyropyridines and the non-thyropyridine. This is a ticagrelor, or we call it Brilinta. We use it in most of our patients with acute coronary syndrome here in the United States. I don't know if it's available in Ethiopia, but Plavix still is, we use Plavix, and prasugrel is antiplatelet we use for patients only who receive stents. But the other medicines, whether it's Plavix or Brilinta, you can use them even in a patient that they don't, they are not going for the cath lab, or they don't receive stents, because these are beneficial to patients with acute coronary syndrome. Ticlopidine, rarely used, causes neutropenia, aplastic anemia, and Plavix, the only problem with Plavix is it takes some time to get the steady effect, steady antiplatelet effect, and it's not as potent as the prasugrel and Brilinta. Like I said, this is we use in the cath lab. We don't use it for acute coronary syndrome that is not going to the cath lab to have stent. And remember, there are some contraindications for use of prasugrel. Patients who have TIA, stroke, age greater than 75 years old, or low weight, less than 60 kilograms, they have increased risk of bleeding. So basically, the medication recommendation as supplements to lifestyle modification, the antiplatelets, aspirin and Plavix, and the other drugs we use, lipid lowering therapy to achieve LDL less than 100 milligram per deciliter. Of course, these days, if you get less than 70 milligram per deciliter, it's optional in high-risk patients. Antihypertensive therapy to achieve blood pressure less than 103/80. Hypoglycemic therapy for hemoglobin A1C less than 7%, and S inhibitor and beta blockers. So with this, I'm going to stop here, and if my colleague Dr. Mikias has anything to add, and then we'll go to the question and answer session. Thank you.
Sounds great. Thank you. Thank you, Henok. And yeah, we have a few questions. And Dr. Mikias, you have a few comments that you want to
add? Yes. So a couple of things.
First, introduce yourself, please.
Okay. My name is Mikias Zametkun. I'm a cardiologist in the Washington, D.C. area. I'm a non-invasive cardiologist. So I call people like Dr. Henok when somebody needs to go to the cath lab for acute MI for stenting. But I thank you for the excellent presentation, Dr. Henok. I wanted to stress on a couple of very basic principles that we need to keep in mind. First, so there is the amount of available resources to treat a patient with acute MI here in the United States is completely different from what you guys are seeing in Ethiopia. And it's even different from one place to another in Ethiopia. It's probably a little bit different if you're in Addis Ababa versus somewhere in the regions outside. So the thing that you need to keep in mind is time is myocardial. So you need to act fast, and you need to use all your available resources in a systematic way, and come up with protocols that fits the amount of available resources that you have in your center. Because, for example, I'll give you one basic example that I see. So most hospitals in Ethiopia do not have the capacity to test troponin, right? So if a patient comes to the emergency room with chest pain, and you are trying to use a send-out troponin test to diagnose acute myocardial infarction, that is a no-no, because If it comes back in 12 hours with a positive result and you have not started treating the patient by then it's too late. So you have to be able to say, you know what, the symptoms are exactly or similar to what I would expect for acute coronary syndrome. I will do an EKG, and if I find anything suspicious, I will act as if the person has acute MI, okay? And the second thing that I wanted to stress upon is, so we have all these fancy things that's we have going for us, right? We have cath labs, we have, you know, we can even replace a person's heart and lungs using what's called ECMO. But medical management is actually very, very beneficial just by itself. So if you deliver the aspirin to the patient very early, if you deliver the beta blocker very early, if you give oxygen to the patient fairly early, if you give them statin, they get a whole lot of benefit, right? So we shouldn't just focus on the most modern and most complex treatments that are available for us. Medical management actually works quite a lot. I just wanted to stress that. That's all.
Okay, that's great. So let's get into some of these questions. So one of the first questions is about anticoagulation. And the question is, you know, for extensive anterolateral myocardial infarction after thrombolytics or revascularization therapy, is there a role for anticoagulation in the long term? If there is any, for what the time and how long do you want to anticoagulate those? And while you are there, there's also a question about, you know, how about those who have also left ventricular thrombus? I guess that's probably a common issue, particularly in Ethiopia where there's a lot of valvular disease. So if you can go around anticoagulation in this patient with MI, without MI, with left ventricular thrombus, and, you know, just put the, you know, your spiel around, particularly acute myocardial infarction and post-procedure anticoagulation. I think that's the first question.
Okay. Can you hear me, Dr.
Yeah,
Grima?
we can.
Yeah, so basically, you know, anticoagulation, like what Dr. Mikias stressed, the medical treatment is very important. Patients drive benefits. So one of the things we do is to start them on anticoagulation as soon as possible. Now, you know, patients, once we take them to the cath lab, put in stent, we don't put them on anticoagulation. In fact, if you see, you know, the bleeding risk these days, even after PCI or before PCI, the bleeding rate is very low in comparison with years back. And the reason for that is, one, after we put in stent, we don't use any anticoagulation. Basically, we don't use heparin. But now the question is, if you don't take them to the cath lab, of course, these patients, they need to stay on anticoagulation for at least 48 hours. The second thing is, of course, if they have thrombus in the ventricle, these are patients who have massive anterior MI. The reason we do thrombolysis or early intervention is actually to prevent, massive MI, myocardial damage and thrombus formation. But if they have already thrombus, those patients need to be on anticoagulation. Now, putting patients on anticoagulation on patients with acute coronary syndrome who receive stent have increased risk of bleeding. Why? Because they're going to be on two dual antiplatelets. They're going to be on aspirin, they're going to be on Plavix. So on top of them are what we are adding, whether it's Coumadin or some other anticoagulants. So those patients, they have increased risk of bleeding, but the recommendation is they need to be on anticoagulation if they have thrombus in the ventricle. Back in the days, even without thrombus, if the ejection fraction is less than 35%, could this patient, benefit from Coumadin? Some physicians, they used to put them on, Coumadin with massive MI without thrombus. but it's not in the guideline anymore. That's but in terms of using anticoagulation with heparins or low molecular heparins, they are very beneficial to patients with acute coronary syndrome.
Dr. Mikias, anything to add to that, to the anticoagulation?
Yes, so let me focus on a couple of things. So I completely agree with Dr. Henok said. So if you have LV dysfunction and let's say apical akinesis on echocardiogram post-acute myocardial infarction, anterior myocardial infarction, it's a class 2B recommendation by the American College of Cardiology to start them on anticoagulation. So it's maybe beneficial. So what class 2B recommendation means. And for the exact reason that Dr. Henok said, because these people usually require dual antiplatelet therapy, we don't prophylactically anticoagulate these people, okay? So the question then is, what if they have an LV thrombus? If they have an LV thrombus, what we usually do, or what I do in our practice, is we drop one of the antiplatelet, usually the aspirin, and keep either the Plavix or the Brilinta, but usually Plavix if we're putting on an anticoagulation, and add an anticoagulant, okay? Technically, the anticoagulant that has been proven to work in LV thrombus is warfarin. There is no data for Xarelto or Eliquis, but we still keep some people on Eliquis or Xarelto for LV thrombus, though there is no definitive data, because sometimes we have difficulty checking INRs, the person is a hard stick, and things like that, okay? So then the question becomes, when do you discontinue, okay? That is a very debatable situation. In my opinion, if there is still persistent apical hypokinesis, which means that the main reason why these people develop LV thrombus is because the apex is akinetic. I think long-term anticoagulation is probably beneficial, okay? And some people actually first present with a stroke and LV thrombus. In those situations, I keep, there is no definitive recommendation, I want to mind you, the anticoagulation indefinitely, okay? Some people stop it because they don't see the LV thrombus any longer on echocardiogram, but I will show you examples where the echo does not show LV thrombus, but the MRI, we do cardiac MRIs. So the cardiac MRI is very sensitive to look at the LV apex, and you still can see LV thrombus. Summarizing, if you have LV thrombus, you need anticoagulation. What to do with it after 3 months is debatable. It's on a case-by-case basis, and you can make your own judgment, but that's what I do. And if you don't have LV thrombus and just anterior myocardial infarction with reduced EF, we don't routinely put them on anticoagulation. That's it.
Well, staying on some more drugs, there are a few questions about ACE inhibitors in these patients with acute coronary syndromes, and dosage and their effects.
Okay, so the question is the role of ACE inhibitors?
Yes.
Okay, so, ACE inhibitors, first of all, can you hear me, Gurma?
Yeah, we can.
Yeah, so patients, who has low EF, ejection fraction less than 40% with acute coronary syndrome, even without the acute coronary syndrome, they have indication for ACE inhibitors. ACE inhibitors, on different trials has shown to improve mortality on different class of, the New York Heart Association, whether it's class 1, class 2, class 3, even asymptomatic patients who doesn't have any symptoms. If their EF is less than 40%, they benefit from ACE inhibitor. Now, in addition to that, if they have, acute coronary syndrome, of course, with low EF, we put them. But these patients, patients who present with acute coronary syndrome, most of them, they have hypertension, they have diabetes. So, they benefit from the ACE inhibitor anyways. So, but the indications are, if you have acute coronary syndrome, less than 40% EF, or if you have massive MI, anterior MI, you can put them on ACE inhibitor.
And Dr. Mikias, you mentioned earlier also a little bit about the novel anticoagulants, DOAC and so on and so forth. So if you can just elaborate a little bit about that. I mean, how commonly it is used in the US, and it's a drug that's not very commonly available elsewhere. And also if you can add comments around the ACE inhibitors and dosage. Are there things you adjust when you send these patients out? Are there dosages you would worry will be detrimental? And and adding there also the beta blockers. And just I think if you can really go over, both of you go over also the beta blockers a little bit more in depth in terms of their use and importance, I think would be helpful.
Okay, so the novel anticoagulants. So there is a lot of data that is coming out about these things. I'm sure you can find a paper that says that they are beneficial as an added treatment in acute myocardial infarction, but the data is not impressive. So if you have acute MI, we treat you with heparin and antiplatelet therapy and do PCI, and we don't use the novel anticoagulants for that. The two main indications that we have and that we use them routinely for these days is non-valvular atrial fibrillation and pulmonary embolism, okay? It avoids admission for pulmonary embolism in some cases, or DVT, because you don't have to get the Lovenox injections, don't have to get trained on how to do Lovenox injections, you don't have to be bridged to warfarin. So those are the main indications that we have. We don't use them routinely for acute myocardial infarction, okay? And as I said, there is no clear data that they help with LV thrombus, but sometimes we use them off-label. Regarding ACE inhibitor and beta blockers. So when we talk about ACE inhibitor, so there are several indications for ACE inhibitors in cardiovascular disease or renal protection and diabetes, right? But the most important one is LV dysfunction. That is a class 1 recommendation. It actually saves lives. So, and regarding the dosing, you need to titrate up the dose to the maximum tolerated dose, okay? And there could be several limiting factors that gets you from getting to the maximum dose, which could include blood pressure, because some people with dysfunction have relatively low blood pressure. Some people have very high blood pressure, so that's good. You can crank up the dose. If they have electrolyte abnormalities, if they have worsening renal function, if they have acute kidney injury, you can't use ACE inhibitor, obviously. So the maximum tolerated dose is the mantra when you have ACE inhibitor. Beta blockers. So beta blockers is, I think, in my opinion, a little bit more complex. So if it is a young person with no conduction abnormalities and has relatively okay blood pressure that they can tolerate the beta blockers, you just crank up the dose too. The higher the dose, the more benefit they get. It doesn't mean that if they have a heart rate of 59 that you cannot give them beta blockers. So, you can drive the heart rate to the low 50s so long as they are not symptomatic with dizziness. But remember, there is a lot of complicating factors when you have a patient with acute coronary syndrome. For example, if they are in cardiogenic shock, you should not be using beta blockers, at least until the time that they get out of beta blockers. And cardiogenic shock is two types, as you know. There are people with normal cardiac output that have fluid overload, and there are people with low cardiac output. And if you suspect that they have low cardiac output, you cannot use beta blockers, okay? Some people have conduction abnormalities. If they have inferior wall MI, they can have AV nodal dysfunction. And until usually this rhythm abnormalities get better with reperfusion, but you should not be using beta blockers until the high-grade AV block is resolved. So that's the main thing.
Okay. So let me add a little bit, Dr. Girma.
Yes, go ahead.
Yeah, so on the dose, usually we start with the smallest dose. Actually, in our hospital, we have protocol. Any patient who comes with acute coronary syndrome, automatically they get lisinopril starting 2.5 milligram once a day, and carvedilol 3.1 to 5 milligram POBID. So this is just automatic. And then you can adjust depending on the blood pressure and the other stuff Dr. Mikias is talked about. So 2.5 for lisinopril, the smallest dose you can start, and 3.1 to 5 milligram POBID for carvedilol, the smallest dose you can start. Thank you.
So I think it will be really wonderful to add those protocols, particularly the medication protocols that you have with either the slides or during this week, so that we can share them with the audience back home. So I have Henok, another question for you. That's about the duration of dual antiplatelet therapy in patients that are being stented. Do you have any specific time you would recommend?
Yeah, so the dual antiplatelets, the recommendations, have been back and forth for several years now, but acute coronary syndrome, whether they receive stent or not, dual antiplatelet therapy for a year.
Okay, give me a second.
So 1 year of dual antiplatelet therapy, patients with acute coronary syndrome, regardless, whether they receive stent or not, especially the patients with non-ST elevation MI, ST elevation MI. If these patients with, what we call it, stable coronary disease who receive stent, the dual antiplatelet therapy is for 6 months. Stable coronary artery disease, dual antiplatelets, 6 months. But if these patients, some of our patients, they have surgery, they want to go to surgery, or if they have increased risk of bleeding, they can stop it in 3 months if they have stable coronary artery disease. For those patients with acute coronary syndrome, if they have increased risk of bleeding, or if they are going for surgery, 6 months is almost good enough. But acute coronary syndrome, 1 year, regardless of stent. Of course, if you put in a stent also, they have increased to prevent stent thrombosis. But this is for drug-eluting stent. For bare metal stents, the recommendation is 1 to 3 months, but we rarely use bare metal stents during this, bare metal stents these days. But the idea is bare metal stents, they require less time of dual antiplatelets than drug-eluting stents. And, drug-eluting stents, of course, they have very small increased risk of stent thrombosis than bare metal stents. So 12 months stable, 6 months. If they have increased risk of bleeding, you can reduce it to 3 months in stable. And if they have increased risk of bleeding, 6 months. Remember, the risk of stent thrombosis is higher in the first 1 to 3 months. Once you reach the 6 months, the risk of stent thrombosis is very, very small. So that's why, these recommendations. Thank you.
Dr. Mikias, anything to add? And, if you guys both can comment also, we have, of course, I'm a vascular surgeon, so we have a very common patient population. And one of the things that comes up all the time is duration of the antiplatelet therapy. When is it safe to take these patients to surgery again, and fix their leg or their carotid or their aneurysm? So comment about, stenting, the coronaries, and taking patients for surgery.
Okay.
Timing.
Okay. Yes, let me make this comment and I will have to depart, unfortunately. And I just wanted to also say, I hope everybody has received the book that we have emailed you and review the first few pages before our presentation next time. But my opinion about discontinuing or for how long to continue anticoagulants, antiplatelet therapy after stenting, it depends actually. It depends on what kind of a stent a person got. The newer stents, you can get away with much shorter duration of antiplatelet therapy, especially if you have an urgent surgery that you need to do, sometimes as short as a month or 3 months, and how complex their coronary artery disease is. There is a difference between a left main stent and a proximal LAD stent versus a distal RCA stent, right? So the amount of risk you run with stent thrombosis with a proximal LAD stent is death. If you have a distal RCA stent, you might have a myocardial infarction. So you can weigh the risk and benefits. So to me, with the newer stents, you can get away with a much shorter period. And if they have complex coronary disease, think twice before you stop it early. That's all I would say.
Great, thank you. And I know the work is calling you, so we'll see you during the week. Please drop in, and we are excited that you'll be presenting on a couple of topics coming up. So thank you for your participation today. And Henok, I have another question for you. You can comment on the issue of your drug-eluting stents and non-drug-eluting stents for patients going to surgery. How long do you freeze surgery, or how long do you want them to be on antiplatelets before they go to surgery, the minimum? And then the second is, what happens if you have a patient with, acute coronary syndrome and they have also some kind of a hemorrhagic stroke? How do you manage those kind of, dual dangerous issues that come in?
Okay, so to comment on the drug-eluting stents, bare metal stents. So like I said, now 90% of 95% we use drug-eluting stents. We are getting away with bare metal stents. So what's the difference? Okay, so let me start from initially when angioplasty was started without stenting. The rate of restenosis was about 30 to 50%. What that means is 5 out of 10 patients, they come back to the hospital because of restenosis. And then the restenosis was because of the vessel required. And then they come up with the stent, the bare metal stent. So the bare metal stent reduce, the rate of restenosis from 30% to 30 to 50% for balloon angioplasty to almost, 10, 15%, 20% rate of restenosis. So the idea is the restenosis, the stent, the bare metal stent, there is what you call its neo-intimal proliferation. There are proliferation of cells within the stent that cause the restenosis. So they come up with this drug. Actually, it's chemo drug. The Taxus, the first drug they developed, is a chemo drug, basically anti-proliferative drug. They put it inside the stent, so it prevents proliferation of the cells. So that's how we reduced the degree of restenosis after bare metal stent. Now, the restenosis rate is very, very low. We don't see patients coming back with restenosis like we used to do. But the problem with the anti-proliferative drug eluting stent is, as much as it prevents proliferation, it prevents also for the endothelium to heal. Remember, the endothelium is the main, covering of the blood vessel that prevents thrombus, and that, the cells have a lot of chemicals that release to prevent thrombosis. So there is endothelialization delay with drug-eluting stents. What that means is the stent stays in the vessel without covered with endothelial cells. That exposes it to increased risk of thrombosis. That's why patients who has drug-eluting stents, they need extended time of antiplatelets than bare metal stents. Now, coming to your question, I have one patient now in the hospital. I saw like 2 months ago, he came in with anemia and acute coronary syndrome. He had proximal LAD lesion, and he was scoped for anemia. He had colon cancer. Now, the surgeon called me and what to do. This patient needs surgery as much as, as soon as possible. So I did ask the surgeon how much time. He said he wants to do it within 3 months. So I brought the patient, put in bare metal stent. If you have bare metal stent, you can get away with antiplatelets only for a month. So I put in bare metal stent, put him antiplatelets for a month and a half. We brought him and he had his colon surgery. So if you think they're gonna have surgery, put in bare metal stent. If you put in already drug-eluting stent, it's very hard to stop it, especially if they have acute coronary syndrome, but you can stop it within 6 months. Like what Dr. Mika said, the new stents are pretty good. They have low risk of stent thrombosis. So you can get away also with 3 months of antiplatelets.
Thank you. And how about, did you have situations with hemorrhagic stroke and acute coronary syndrome?
Yes. So that's it's very difficult. Sometimes actually we have patients who has stent, drug-eluting stent, and they develop hemorrhagic stroke, and then we have to stop the antiplatelets. There is no, this is very difficult. So we stop the antiplatelets. There is no way, we can continue with antiplatelets while they are having hemorrhagic stroke, because it's going to kill them.
Yeah. One last question is, how do you define chronic coronary syndrome? I mean, we talked about acute coronary syndrome.
Yeah.
What are in that category of chronic? Yeah.
So the chronic or stable coronary artery these are patients, they have chest pain, but the chest pain is tolerable. It doesn't increase in intensity. It doesn't increase in frequency. The patients, they can tolerate it. And, sometimes we do stress tests. When we do stress tests, they have very small area of ischemia. So we say not cut them, just treat them with medicine. Of course, if their chest pain is unbearable, then, we take them to the cath lab. But those are the stable coronary artery disease. They have some chest pain, but they can tolerate it with medical treatment. That's what we are talking about, coronary artery disease. And also, there are patients that we take to the cath lab, but they have disease, they have plaque, but the stenosis is less than 50%. They have some disease, but it's not bad enough to put in stent, or the stress test is negative. Those are the patients we call them chronic coronary artery disease. Of course, any patient who has coronary artery disease is chronic by definition.
Well, Dr. Henok, thank you so much. Is Dr. Tesfaye Talila on the call? If he has any additional thoughts before I close. I did not see him, but yes.
Yeah, can you hear me?
Yes, we can. Do you want to say a few words?
Yeah, sorry, I stepped away to see an emergency patient. Can you? Yeah, I just started the last part of this talk, and yes, after you put a stent in a patient, if you have to take them to surgery, I completely agree with what Dr. Henok just said. Sometimes I have used a new drug called Cangrelor, which is a IV P2Y12 inhibitor. You can, it's a quick onset, quick offset type of medication that you can actually bridge it to surgery. I had a patient who came in with ST elevation myocardial infarction and also a bowel obstruction at the same time. So I fixed the right coronary artery with a stent, drug-eluting stent in this case, and I put her on Cangrelor. So she was on Cangrelor, and they turned the Cangrelor off, took her to the surgery, had colectomy, and then right after the surgery, she goes back on Cangrelor. Unfortunately, this medication is a fairly new and fairly expensive medicine. but it can be used in that very, tricky situation. Otherwise, yes, I completely agree with what Dr. Hanok said.
Well, thank you very much. So I think to be sensitive about everybody's time, and we are just a little bit over our hour that we have allocated. Dr. Tesfaye will be also coming back to do some presentation during this 2-week webinar. I hope everybody enjoyed the presentation, and I definitely enjoyed the question and answer session, and also learned a lot actually. And if you have some additional thoughts and questions, please jot them down, and when we meet again on Wednesday, we can go over some of your questions, even from the presentation from today. And as usual, we'll make sure we share the slides with you, and Malak will send those your way, and we'll also make sure we get this presentation online at some point soon, and share that with you as well, so that you can see it at your leisure. You can maybe read a little bit more for those of you who are residents and students, and then go back and listen to the presentation, and that may make even more sense to you. So with that, I just say bye today, and we'll see you next Wednesday morning, the same time. And I really want to say thank you, Dr. Hanok, for this amazing presentation, and also a great question and answer sessions, and more to come. So have a great day. Bye.